Ladies and gentlemen, good morning. And thank you for joining me. Okay, so suicide and epilepsy. It's an important topic. It has many implications. But allow me, before I start with the presentation and the data and whatever, to share you a couple of wonderful moments we had in the past 2 weekends. Last 2 weekends, the first one was we celebrated the success of our International Abu Dhabi Mental Health Congress. I'm sharing it to you because it was wonderful. I was through wonderful 2 weekends. So this was the first weekend when we celebrated the success of this wonderful Congress, which was successful by all means, with the help and the sincere efforts of everybody, Dr. Tariq, Dr. Medhat, of course, the director of the program, and all the faculties, and all the coordinators, and all the moderators, and everyone. So it was a wonderful weekend. Then last weekend, it was also as wonderful, because I was in Dubai, and I was attending the annual International Congress of Epilepsy. It's part of our Emirati chapter for the International League Against Epilepsy. I'm a board member for the chapter. So this was the last weekend, and it was also wonderful and successful. And it was more nostalgic. It was full of so many beautiful memories and seeing so many beautiful faces. So allow me to talk a few minutes about this. The Emirati chapter of the International League of Epilepsy was established in 2009. Dr. Tawfiq Sa'di, who is the senior consultant neurologist and used to head the Department of Neurology here, he said, Mufeed, we need to start our own chapter in the UAE. And we started that, and there were 4 of us, with Dr. Wasim Fathallah, the consultant child neurology, and Dr. Ayad Khudair, who is a consultant neurologist. And now we have 70 neurologists, and we have doing our annual congress regularly. And every year, the audience are increasing. And we are trying to keep the caliber just like we are doing in our psychiatry conferences. We are keeping raising the bar and getting more speakers. So it was a wonderful event. We had 2 important guests. The president of the International League Against Epilepsy, and he gave a talk. I would ask him to share it with me, to present it to you. It was treatment of epilepsy in the 21st century. Something amazing. And it's beyond what we can imagine, how science have advanced now. What are the things they are doing now? So they are even thinking that maybe epilepsy will come to an end with the available treatments they have. And at the same time, I said it was nostalgic because among the audience was my senior neurologist who was my supervisor back in the 1990s when I did my PhD in epilepsy. And 2 of my colleagues coming from Iraq, they were among the audience. So it was highly nostalgic because it brought me back to 1999 when Professor Samad al-Fahadi came back from the International League Against Epilepsy Congress, and he said, Mufeed, we have to start our own chapter in Iraq. And we did. And also there were 4 of us. And I do remember all these good times when I was working hard, days and nights to prepare the constitution of the chapter and the bylaws of the chapter, and then I had to prepare the Arabic version. And we started that chapter. And when I left my country in 2006, we had more than 100 neurologists, neurosurgeons, and psychiatrists among that chapter. Forgive me, but it was full of positive energy and emotions. And because I love you all, I wanted to share it with you. Okay, back to epilepsy and suicide. My intention, I did put the references first, because when you go through epilepsy and suicide, you will find hundreds of papers. And these hundreds of papers, they have been over decades. and as it's made red at the bottom, the results are conflicting, or they are different, not conflicting. Let me be more precise. And I'm sure you know why the results are different, because they are different, the studies are different, and the research design, and the outcome measured, and most importantly, the sample. That's why you have different grades. For example, mental health problems among people with epilepsy, you find it ranging from 20 to 78%. This is a very wide range. So when I went back through all these papers, the main factor is the different sample. And I keep saying that important statement that we have to differentiate between patients with epilepsy and people with epilepsy. Patients with epilepsy are the patients that are recorded in our register, in our clinical units, in our hospitals, in our specialized centers. But people with epilepsy are all the people with epilepsy who are in the community. Some of them have attended and are registered, but many of them, they did not ask for help, because they are not there. So the different studies, some of them are community studies. Some of them are done in specialized epilepsy surgery centers. Others in general neurology clinics, in general hospitals. That's why the results are different. So forgive me, I did not cite the references inside the slides. I tried to get what is the agreed upon outcome, and I will try to present it to you. And I keep citing, and this quote from Sir William Osbert, that the good physician treats the disease and the great one treats the patient. And this is a gap we have. When we talk about people with epilepsy, this is a major gap. I will talk about it later. So this is the outline of my presentation, introduction. Then generally we'll talk about suicide behavior, then suicide among people with epilepsy, and what are the recommendations. People with epilepsy, you know that they are disadvantaged, and actually among people with chronic neurological disorders, you know the most common chronic neurological disorder is epilepsy. Name all other disorders that are less prevalent. And epilepsy, the lifetime prevalence is 0.7 to 1.2%. And they are disadvantaged in so many ways: loss of independence, and underemployment, decreased leisure time, decreased physical activity. They are unable to drive. They have problems in obtaining insurance because they have epilepsy, and they have higher rates of substance abuse. And all of these adversely affect their quality of life. In addition, epilepsy being a chronic disease, it has a much higher rate of comorbidity, psychiatric and medical, and both also adversely affect the quality of life of these people. So generally speaking, psychiatric comorbidity, the agreed upon rate is 30 to 50% in refractory or chronic epilepsy. Why do these people have comorbidities? It has been debatable, and there are so many factors. Why people with epilepsy, they have higher rates of comorbidities? Is it because of the common underlying predisposition, something shared, genetic, biochemical? We are not sure of the answer. Is it the direct effect of the seizures? Because seizures are trauma to the cerebral cortex and to the brain function. Is it because the underlying epilepsy etiology, if it is focal, I mean, if it's secondary to a tumor or whatever, is it the psychiatric comorbidity secondary to that etiology? Or is it because of the adverse effects of anti-epileptic drugs or other therapies? Or, as we usually say, as a sequelae of psychosocial problems and disadvantages. Neurologists usually treat the clinical seizures, and their main aim, and I said that to all the neurologists. I was one of 2 psychiatrists among 380 audience. They were all neurologists. And usually, and it is true, their main aim is to control the seizures, to make the patient seizure-free. But they never ask about psychosocial aspects and psychiatric problems. And psychiatrists, on the other hand, they don't receive sufficient training in how to handle psychiatric problems among people with chronic neurological disorders. I'm sure the consultation liaison psychiatry is doing that, focusing on that, but that is the worldwide data that psychiatrists graduated. They are not, they don't feel very well equipped and competent to handle this. So psychiatric disorders on the other side, and when people with epilepsy, they are underdiagnosed and they are untreated. They're 3%. And more severe forms, they don't receive enough treatment because the doctors are hesitant and they are occupied-minded with the myth that all psychotropic medications are epileptogenic and you have to stay away from it. So this all raise worrisome consequences. Worldwide data, they do agree. In the UK, in Canada, in the States, in the generally in Europe, even in our region, in the part of the world, and you are aware of the research papers that were published from SKMC, that depression and anxiety are higher among people with epilepsy, significantly compared, and what's added to it is suicidality. And all this needs to be considered and need to be put in mind when we deal with these people. Yet, there are many sound papers and literatures showing that suicide is increased among people with epilepsy, even without psychiatric comorbidity. And that will bring them to the other causes of suicide that's not related to epilepsy. Is there any chance we increase the light? I don't want people to go to sleep. Something, yeah, at least. Yeah, it's very